Thank you very much, sir, for having me here. It's a great honor. This I am restricting to, as Dr. Lalit Verma said, medical management, and of course macular edema also will be subsequently dealt with Rajiv, so I am just not going to touch macular edema, maybe just a brief running through. So basically, PDR is a vasoproliferative disorder, and when you manage these eyes, you need to have most important factor comes as a appropriate workup. History, you need to look for duration of diabetes, symptoms, underlying systemic factors, patient, which medication is taking, and particularly history of rapid progression of the disease. Clinical examination, obviously baseline vision. When you look for anti-segment evaluation, look for NVI and NVAs and conventional methods of fundus evaluation. Systemic evaluation is extremely important, particularly duration of diabetes, how well it is controlled, and associated systemic hypertension, renal disease, and cardiac status. Coming to the imaging, and we all know good metabolic control is an integral part of a diabetic management, so fasting and postprandial sugar, HbA1c, serum urea creatinine, basically again looking at a renal status, hypertensive, and lipid profile, and good diabetic management. Coming to the ocular investigation, generally imaging complements the treatment approach to the patient with a PDR, and when you look at it, FFA is one of the most time-tested baseline evaluation to detect subtle neovessels, ischemia, perfusion defects and changes. For obviously new vessels, when you have or NVD or NV, you do not need FFA, but with subtle changes we know obviously FFA adds on your decision making, and also helps to guide laser when you are having associated macular edema or when you plan fill-in laser photocoagulation. And when in cases with the asteroid hyalosis, so sometimes visibility is extremely difficult, what FFA gives you excellent view to plan your subsequent treatment. Ultra wide field imaging nowadays helping us a lot. Look at conventional 7 field, and now ultra wide field gives you almost 11.7% of more detection of new vessels, and also almost more detection of new vessels, NVEs, in a peripheral area and as well ischemic areas. As this is showing, you have a clearance picture having photographed peripheral new vessels and CNP areas, which obviously beyond 7 field and conventional photography would not have helped. Also it helps us in assessing adequacy of pan-retinal photocoagulation. OCT helps you identifying macular edema. Of course, clinical examination equally important, but subtle edema obviously we can pick up well with OCTs, and also associated morphological changes probably helps you in discussing prognosis with the patient. So it also helps to assess vitreomacular interface, particularly when you look at epiretinal membrane, vitreomacular traction, and then various tractional components, whether PVD is there or not, and that is what OCT helps us. Coming to the OCT angiography, it's a non-invasive technique now, more extensively being used, but it's still, I would say, not yet substitute for FFA. So it helps to detect mild perfusion defects, layer-specific perfusion changes, and you have a better understanding of foveal avascular zone, its regularity and pruning of the vessels. It also helps to detect the new vessels at the interface of retina and the vitreous, sometimes which can easily to miss. And of course, last in the investigation armamentarium is your ultrasonography, where you have a media opacity. So ultrasonography helps us to know the status of the retina. Again, posterior hyaloid status, its attachments, associated vitreous membrane, and vitreous schisis. This is just a picture showing a large wide spectrum of what we call as a PDR. So we'll go clinical scenarios one by one. This is a patient with a 63-year-old male, recently diagnosed diabetic, vision is 618, fundus evaluation and FFA shows isolated single NVE. How do you manage? Probably, of course, you again need to assess macula and overall perfusion status. You can, technically it is like a non-high risk PDR, so you can have a close follow-up, and possible options will be, as I said, observation, or conventional PRP, targeted laser, or intravitreal anti-VEGF. However, we prefer PRP in a certain situation where you assume if there is a poor compliance to follow, if there is advanced diabetic disease in other eye, if there is a poor control of systemic parameters, and if there are wide areas non-perfusion. Targeted laser can be attempted where to ischemic and CNP areas, but the advantage is not to destroy healthy, well-perfused retina, but at the same time, you need to have very close follow-up for fresh new vessels, and sometimes it will be difficult. Intravitreal anti-VEGF monotherapy, yes, it works, but problem is repeated injections, so cost is an issue. There is a need to frequent, careful, lifelong follow-up, which again subsequent studies have shown may not, with sometimes difficult and practical issues, and if there is a failure to follow, there is a reactivation of neovascularization, even progression to neovascular glaucoma as well. This is another patient with 55-year-old male, diabetic, vision is 6.6 and 6, and what Octa shows is multiple NVEs all around. So probably this is a ideal patient. I would prefer to PRP, which again evidence-based and experience all of us have, though it is partly again supported by DRCR Protocol S. So what Protocol S says is to compare the safety and efficacy of PRP to intravitreal injection of ranibizumab for treatment of PDR. So, and particularly when you look at a 5-year analysis and looking at a loss of follow-up in this population, which is very, very high, PRP probably a potential to complete in 1 or 2 sittings. There is no risk of endophthalmitis, and have overall long-term, both are probably equally good. So practical aspect, when you look at it, probably PRP still is better off in our scenario. What are the ideal candidates where probably you would choose anti-VEGF, where you have associated diabetic macular edema, no macular threatening traction, if there is a recurrence of neovascularization after good PRP, and associated partial minimal vitreous hemorrhage which prevent completion of PRP but no visible traction. So high risk PDR, DRS has already proved that PRP reduces the risk of severe visual loss. And when to commence PRP basically is ideal to prefer to start as early as possible, as a delay again can reduce overall final functional outcome. So all of us know high risk criteria. I am not going to go in detail, and ETDRS goes one step ahead, considering that even severe NPDR should be treated with PRP. Now, how you do laser photocoagulation? Generally, these are create a chorioretinal burns of a mild to moderate intensity with a 1 to 1/2 burn width apart, and you extend up to arcade superior inferiorly 1 disc diameter area nasally and probably 2 disc area temporal to the macula, and that's what ideal way of doing PRP. So when you add additional PRP, particularly when there is failure of neovascularization to regress, you need to give 2 to 3 months of time. Generally, that's what we follow. If there is no satisfactory regression, if there is space available, you add on some more laser. You can increase the areas going closer to the temporal side, probably toward the macular area, and generally burns are placed in between previously treated area. So this is a 48-year-old male, had a diabetes, having a loss of vision since 2 months, diabetic since last 5 years, vision was 624, and had a PDR with CMIN. Probably this is the case. Ideally, you can have, though you can try anti-VEGF monotherapy, but all of us would prefer combined anti-VEGF therapy along with PRP. But if there is diabetic macular edema and associated traction, surgery would be the better option. When you deal with a neovascularization, this is the case, having a DOV since last 1 year, vision was 636 in the right eye, left eye was 6 by 7.5, had asymmetric PDR. These are typical eyes where other eye is normal. You need to investigate them thoroughly, particularly dealing with a more like ocular ischemic syndrome. Patient had a right carotid artery stenosis. You need to treat for the same when dealing with this type of patient. I am not going to go in detail with this big chart, but when you deal with NVI and NVA, you have to be really aggressive, which will probably help to reduce neovascularization of angle and iris. And early detection is the key here. Really, both combination of anti-VEGF and aggressive PRP, and sometimes I go one step ahead doing even anterior retinal cryo as well to when deal with these eyes. So when come to just mild vitreous hemorrhage, is a 50-year-old male, had a loss of vision since 1 week only, non-diabetic last 14 years. He already had a laser done previously. Fundus view was there, no traction, so we decided to wait for a while and then add on PRP to the skip areas, and patient is doing well. The another case with having a vitreous hemorrhage, some view was there, no macular traction, no previous laser. These are the patient, and when have a, obviously you rule out traction, can be followed up closely at couple of 2 to 3 weeks interval, and as we start clearing, you still can add on laser. Probably this can be the case where you even add on anti-VEGF to support it to buy some time, and eventually, but laser probably will be the treatment of choice in this scenario. Coming to cataract combined with a PDR, if you have a retina is view is visible, I would prefer to stabilize the diabetic process first and then consider for a cataract surgery. But if there is no view of fundus, you assess the patient on ultrasonography, there is no obvious traction, then probably can go ahead with the cataract surgery and earliest possible opportunity, evaluate the fundus, and then plan your treatment depending on the stage of the diabetic retinopathy. To summarize, PDR is a proliferative vascular retinopathy seen in diabetics. Laser PRP is still a mainstay of treatment for PDR in our scenario. Anti-VEGF can be combined with PRP in eyes with center involving diabetic edema and recurrent neovascularization. Role of anti-VEGF as a monotherapy is still debatable, but in advanced diabetic eyes, pre-surgery intravitreal anti-VEGF helps to minimize intra-bleeding for more complete removal of fibrovascular proliferations. Tractional detachment is the commonest indication for vitrectomy, and early treatment and good metabolic control gives a better final outcome. However, long-term follow-up is essential for these patients. Thank you very much for patient. I would like to acknowledge Dr. Rajiraman, my two fellows, for helping me to create this presentation. Thank you very much.
Excellent, Pramod. I think you have summarized. Any one of the panelists differs from whatever he has said? Any difference of opinion?
In my audit of about 250 patients of proliferative diabetic retinopathy, I had about 12% incidence of bleed within the first 2 months of laser photocoagulation. And so if it is near the arcades, I will consider an injection than a panretinal photocoagulation.
So Gopal, if you consider injection, you do it after the laser or before?
Before the laser.
Before the laser. That is treatment naive patient of PDR. You will start with anti-VEGF injection.
One injection followed by laser.
One injection followed by laser.
Over 2 months, I will complete the laser.
How many days after injection?
Maybe a week.
A week.
If there is no visible traction.
Yeah. Yes, Andy.
So one of the things I like to look for in a patient with proliferative diabetic retinopathy is venous beating. I think venous beating is the most important sign when we look at all the various features within diabetic retinopathy, cottonwool spots, hemorrhages, microaneurysms, ERMA. Venous beating, I think, is one of the most important features. I, therefore, titrate the amount of PRP I do based on the extent of the venous beating. So if a patient has really extensive venous beating, that tells me there's a lot of ischemia, and I'll do a heavier PRP, as you suggested. Whereas if it's an older patient, 60, 70 years old, and they have a couple small fronds of retinal neovascularization, they're bleeding, but they have very minimal venous beating, I'll do a more broadly scattered PRP. So I'll track it that way. And then post-laser, you expect that venous beating to go away over 6 months, a year or so. So if a patient comes back 2 or 3 years later with a recurrent vitreous hemorrhage and the venous beating has gone away completely, I know that vitreous hemorrhage is secondary to traction. It's a mechanical vitreous hemorrhage because the patient developed a PVD, and although we expect PRP to induce regression of the retinal neovascularization and disc neovascularization, there's still some persistent neovascularization, and so it's purely tractional. Whereas if there's persistent venous beating after my PRP, then I know they need more laser also.
So you still depend on laser. You see, you think that bleeding is more indicator of ischemia. Yeah, I think he stressed that. Only thing he was stressing on angiographic CNP areas and other things. But venous bleeding, I think all of us agree on that. The only thing I wanted was that Dr. Gopal said that he may start, only difference, Gopal, I have, whatever you said was that not in any PDR, but only where the fronts are on the posterior pole. You see, sometimes you have situation where if you have front right on the arcade, where laser
in which a PRP can actually cause a premacular bleed very rapidly and very unhappy patient also.
So anybody else who starts the management of PDR with injection?
No, certainly I would give an injection, but with the first sitting of PRP at the same time, which would take, the injection would take care of the...
So you are dependent more on laser, not on injection?
Absolutely. The dependence is only on laser. The anti-VEGF is only to prevent an immediate bleed as well as maybe the DME worsening or starting.
Nobody can titrate whether this will bleed immediately or not. You see, nobody can tell. There's no parameter.
If we do not want the risk of bleeding for whatever reason.
You see, for all these decades, we have been managing, and for not 1 decade, 2 decades and decades, I think all of us have good photographs to show that it's an excellent treatment. Laser is still the gold standard. And as Andy was saying, if there is venous bleeding, you add more laser rather than pushing this short of anti-VEGF. Anti-VEGF means repetitive, and you need to follow whether patient will be compliant enough to follow or not. That was the issue. And with the industry pushing us to, keep injecting, that was the issue. Yes,
but, we should keep in our mind that PRP has some the visual field effect that will result in. So initially, it is better to start with this anti-VEGF if there is some amount of edema is there.
Edema, I think there are some things which are very clear. That with edema, everybody, DME, I don't think so anybody, that is very clear. PDR with HRC, very clear that tight PRP is the answer. But it is those grey zones where, people keep injecting. I was bothered for that. PDR with DME, I don't think so anybody in the panel will have any difference that we start with injections and other things and add laser. But it is the pure PDR. I think Pramod brought out very, very clearly. Therefore, I asked first question was anybody differs with him or not?
Just in my opinion, I don't think so, sir. Laser is still the gold standard. It holds good, but only in select cases like when there is a pilot.
1, 2, 3.
If he's a pilot, if he's a pilot, if he's in the military, in those cases, the field of view definitely becomes important. So,
the question is not about continuing the injections with protocol S, but the thing is about one injection followed by PRP.
Yeah, what do you say?
No, the question is not about continuing the injections. That nobody is going to do here, because we will all do pan-retinal photocoagulation.
Very good, very good.
The question is,
another very good point.
Another
very good point. I think Mallika also was stressing, and Gopal has said, in PDR, repetitive injection may not be required. It's just one maybe injection just to facilitate or to reduce the chance of bleeding. That's what Mallika was hinting.
Exactly.
Yeah, that is.
Yes, last Rajiv.
Just to add that the thing that field restriction will be there, it also happens with anti-VEGF. So at 5 years follow-up, protocol has actually found that the field effects are same, because there are though the ischemia still continues.
So what will you tell your pilot next time? Injection or laser?
of course, I would still prefer laser in doing that. But in those cases, if there is only a focal NV,
so I think,
I would still like to do a targeted laser. I don't want to be too aggressive on these patients.
No, I think
unless they have an NVD,
perfectly okay.
unless they have a
neovascularization.
neovascularization.
That the laser is the mainstay. Injections have an adjunct value only. Adjunct value means facilitation of this thing, or recurrence patients, or at a very sensitive area you have fronts.
I have a point, like if if the DME is not there and the patient is having PDR, 2-3 neovascularization, so give single dose of anti-VEGF followed by PRP so that you can titrate the amount of PRP to decrease the visual field effect.
Boral, I still wish that, starting with injection may not be a wise option. You see, starting with yes, Ajay, you want to make a comment?
I have a small question. Does the panel differentiate between a flat NB versus an elevated NB? Yes. Because that is, to me, important if I wish to decide whether I want to give an intravitreal injection or not. Second, this is just another spin I want to add, that we have been following a few cases, it's not a large series, we have done a targeted laser and added a micropulse PRP in these cases just for the sake, and it is working.
Ajay, everything is not micropulse. Everything you tried to. Okay, so let me ask Pramod BHENDE about this.
Don't have much experience with micro, though we have.
No, his question difference between elevated and flat.
So actually,
approach.
because elevated obviously again indicates there's some amount of PVD is there. Basically what happened, flat one, yeah, probably use, but I think either way I would prefer given option is, my first statement is always laser photocoagulation. Yeah, but what happened when having a flat proliferation, we have that indicates no PVD. I would prefer definitely, I tell fellows that have a light burn always. Because the problem there is sometimes you nail down, if a heavy burn, you nail down posterior hyaloid. Subsequently, when they bleed and when you take them for surgery, PVD induction can be very, very traumatic, difficult and traumatic also for the eye.
Okay, we'll have last comment from Sangeet.
Sir, it's not a comment, just a situation that is commonly present is, sometimes we have those multiple extensive fronts just bordering the macula and not involving the macula. The vision is 6'9", 6'6".
Yeah.
And when you do laser, suddenly the traction happens and the retina gets detached. What is the...
Correct.
So one last question.
So I think, let's...
Yeah. So one last question. If a multi-millionaire person is coming to you...
Multi-millionaire?
And he's ready to spend N numbers of injection in the next 10 years, what will be your choice?
Answer is still gold standard. I don't think so we change with pilot and multi-millionaire. That has no role to play. You see, ultimately we have to stabilize the eye, not the dollars and all. Don't worry about that. I don't think so. You see, it is relevant. Even owner of Geo Center, Mukesh Ambani comes. My session will be laser.
So one point. One point last. If you have, I have seen several times, if you have missed PDR before cataract surgery, then after cataract surgery, you may get a situation like endophthalmitis. And we've even proceeded with vitrectomy to find that it was actually hemorrhage and it was NVG. So NVI can present immediate post-operative cataract surgery as inflammation, severe inflammation. So look at the iris. If there are new vessels, then inject anti-VEGF, not